My pleasure to introduce Dr. Salim Balik. He is from my alma mater in Turkey. He's a distinguished medical physicist and assistant professor at the Department of Radiation Oncology, Keck School of Medicine, University of Southern California. He did PhD in physics, and then some academic research, then clinical practice, and then some leadership roles at USC. So at USC, his current role is interim chief of physics and medical physics residency program director. And he led a multi-site team through some critical accreditation processes, program expansion, and quality assurance initiatives. So let me help me welcome Dr. Balik.
Thank you, Erkan, for the nice introduction. And yeah, I'm the medical physics program director at USC. I was the intern chief years ago. Now, my background is that, from the United States, 2000, and I did my PhD in atomic physics. So, and then I switched to medical physics. But I visited Erkan's lab and looking at the optical table and all the stuff that like make my memories of time when I was in PhD in the lab, tuning the laser, working, getting the spectrometer right, and everything is right, just right, so that I can collect data. I did some ultra cold physics, radiation trapping, for the light computation in the ultra cold retail. And also, that is still my chief secret like available. All right, today I'm going to talk about something different, about medical physics. So I divided my talk in like three. First, I'll talk a little bit about the history of medical physics and what are the treatment options or the modern treatment machine right now. I'm going to go overview what are the things we do. Okay, that should give you an idea of what medical physics do. Okay, that's like one of the difficult questions that I get. In medical physics, what do you do? It's very difficult to explain because there's a lot we do in the clinic, and it's very difficult to explain in just like one or two words. And then I'll finalize. If anyone, like for the students, if they are interested in the career in medical physics, I'll go over like how they can become one. What are the options in the for to get medical physics, or also like maybe a dosimetry. And I'll go over those things. So medical physics is an interdisciplinary field combining physics principles and with health in healthcare. Okay, we try to improve the diagnosis and treatment of diseases by implementing novel imaging technologies and also radiation therapy. We play a crucial role in the development of the medical imaging and radiation therapy technologies to ensure the treatments are not only effective but also safe for the patient. So starting from with Röntgen, its discovery of the X-ray radiation revolutionized, like starting the field. It allowed physicians to see inside the patient without actually like opening up. At that time, it was impossible. So that was very revolutionary. You got the first Nobel Prize. The first Nobel Prize history was awarded to Röntgen. And when we talk about medical physics, like the first person that comes into my mind, people's mind is actually Marie Curie. Her work in like radioactivity has like really revolutionized the medical physics field, and she is the first one who got the Nobel Prize, and also third person who got like Nobel Prize in the field. And, her husband got the Nobel Prize, and the day she was born is like celebrated as the Day of International Day of Medical Physics, which was like last week this day. So what brought probably the biggest development in terms of in the medical physics area is the development of the linear accelerator. Majority of the treatment options right now using for the medical physics is, or radiation oncology is using these linear accelerators. They allow us, to use very high energies that can penetrate deep into the tissue and treat tumors. And like throughout, like it's like starting like in 50s, it all came with the development of Firestone and the Firestone and magnetron, so that you can accelerate electrons. And that technology may be possible with our current linear accelerators. To this, we use those linear accelerate electrons to produce high energy photons. And then I'll mention Barzexel and his work in radiosurgery. He developed the concept of SRS, which we call as therapeutic radiosurgery, and he designed the first gamma knife. So since then, there were like many iterations of the gamma knife. So it's all his idea, like and then evolving as the technology develops, getting it better, more precise. And so they're like, of course, without imaging, really, we can't really do like anything we do now in the field of medical physics or radiation oncology. Okay. You mentioned of the computed tomography having like 3D images of the patient, and also like the MRI, in combination with these, then you can actually diagnose the disease better, and also target and treat them better. And then we can bring these images into our treatment planning software, and actually we can design a treatment. Okay. So in addition to the imaging technology improvements and advances in computer control treatment planning together allow us precise calculation of the radiation that we will deliver to the patient. Okay. And the software now it allows us to integrate multiple images so that physicians have all of these images available for them to accurately contour or outline the disease that we're going to treat. And then with the introduction of IMRT and VMAT, we can actually shape the dose. Okay, so we can actually we can treat the spine without actually harming the core, which is like in the middle. So we can actually relieve the outside area. So this is possible only via intensity modulated radiation therapy and and also the volumetric modulation therapy. Okay. Now nowadays, coming to 2020, now we're doing adaptive radiation therapy. So the patient, the standard radiation therapy is patient is simulated, and we make a plan, we deliver that plan, we fractionate it. Okay, we deliver it in probably 5-6 weeks. Okay, something like that. It varies, but let's say that like that. And then throughout this time, the patient's anatomy change, tumor change, and we're still delivering the same plan. Now with adaptive radiation therapy, we can actually adapt to the changes in the patient's anatomy.
Right? Do that tumors require multiple imaging sessions?
Yeah, of course. And that requires patients to come again, you image again, you make a new plan, and then now it's actually with the some of the machines that we do now, you can do what we call is online adaptive, which is patient on the table, you image it, and then you can actually react at that time to the changes in the anatomy, because not only tumor shrinks, also there's moves. Okay, nothing is in our body is stationary except maybe bones. Okay, if you're shrinking pancreas and the bowel, duodenum, stomach, all of that is in the way, and every day the shape is and then everything is changing. So to adapt to those changes, you need adaptive strategy. So with all these now advanced these systems, we can actually calculate the dose faster. Dose calculation or that computation, it takes time. Typically, what we do is we simulate the patient with imaging, and then we work on the plan several days, and then maybe 1 week later we can treat. But now we did all these developments, we can actually adapt the plans, patient on the table. We call it an online therapy. And then all of that is possible partially because of the automation and efficiency brought with these systems. And now we're in a new era with all the AI. So we're getting all the benefit of that too. and that allows help the physicians to order contour and help like on the imaging session because there's a lot of work to fine tune and like while patient on the table for adaptive radiation therapy now. Machine learning or the algorithms can help you like automatically contour and solve it instantly on the patient on the table and like on the treatment position, you can change the plan. Okay, good question.
Yes.
Yeah, how common is it to use machine learning and AI in reality today, as of today?
Oh, we do it right now, but in our clinic, there are several software, and we are in this, I think, the baby steps of all of that, but things are getting like improving. There's so many, anything we do here, there's a research project going on that, like how we can do this using like AI, machine learning. Yeah, like I started my work in like image registration, that was my research. Now, all of that is not done by this image registration now, it's like that work is mostly done with AI. We have a software right now. I mean, that was again 10 years ago, it was like a research phase. Now we have actually, software that we can use in our clinic right now. We can do things.
Something like
we were doing research 10 years ago.
So is it like the software that has to be approved before using it? Like
yes, right, of course. It is like FDA approval and also it goes through rigorous. You buy and implement the software, you have to test it. We call it commissioning. That's like our physics job. So anything technical, like advanced, that comes to the physics, it's like, okay, can we use this? And the physicist has to do like rigorous, testing the equipment and then make sure that software fits your department's needs, your clinical needs. Every clinic and department like acts slightly different. All right, so there are some different specialties in medical physics. So like I'm in the therapeutic, the first one, therapeutic medical. I work in radiation oncology department of the hospital. Okay. So the things that I do is different than a diagnostic physicist do. So most of the, since I know therapeutic physics part, I'm going to talk about more in the therapeutic physics part. Okay. I'm going to just mention what other things are. So if you're interested in those, you can explore as a career option. But most of the stuff that I talk about today will be in the therapeutic medical physics area. This is our resident fund. He's doing some NUJ on the machine, and so that's one of the things we do: quality assurance. Make sure the machines that everything is operating properly. We, like I said, we focus on the radiation therapy and treatment of the cancer. But also there are other diseases, other things we do. I mean, like there's, for example, radiation can be used for the AFib. Okay, it's not cancer. It is, AFib is like there's a heart beating irregularly. So it's a heart condition. So it is used now for radiation for that. There's like in the brain we use for ABM. There's like like a lot. There's an anomaly in the brain that actually can cause stroke. So basically, it can bleed. So maybe we treat that regularly. That's not a cancer. So there are like several things that we do with radiation, but majority is in the radiation oncology, cancer. Okay? And we do all that calibration of the machines, QA, etc. So diagnostic is on the other end. They work in the radiology department with this radiologist more closely. Okay, and on the X-ray, CT, ultrasound, making sure those imaging modalities are functioning properly. Okay. And there's nuclear medicine. They work on the reactive traces for imaging and therapy. It's like you probably heard this iodine 131 treatment. Like you give that iodine to reactive drug. You give to the patient that goes to the thyroid and that's treatment for the thyroid cancer. The nuclear medicine can do that. There's also like imaging, PET imaging. For example, you inject the patient with PET tracer, fluorine 18. Okay, then I don't know if you guys it's a positron emission tomography. Okay, now I'm going to the slide about that. But it's in their field. That's what they do. And how physicists are usually the RSOs in the hospitals and they show radiation safety. People are following the rules, and also everything is compliance with the regulatory regulations, NRC regulations, etc. And then there's also MRI physics. Okay, it's message, they are specialized in the MRI machine. So I'm gonna go over now some of the, modern, therapy machines and also some treatment options. And these are the things that we do every day, okay? Not every center will have one of these, but, probably you've heard some of this, and some center will have one and another center will have the other. But all of them are used to treat cancer, mostly, okay? The most versatile machine that you can do almost anything is the accelerator. So every hospital, every clinic will have one of these, okay? This has this is the gantry. It has a long waveguide that allows energies up to like 1820 MV, okay? From 6 MV, megavolt, okay? So it's like high energies. For the CT imaging, it's only 120 kV, okay? That's what's used energy on the X-ray. For these, we use 6 MV. All right. So those are like, it allows higher energies to shoot, okay, because of the longer waveguide. And then it rotates around the patient, the gantry rotates, and also couch, the treatment table also rotates. It allows us to, attack the tumor from different directions. It also has electrons, not only photons, it can produce electrons. So you can actually treat superficial tumors, some skin cancer, etc. So it's very, like I said, versatile and wide range of applications. Okay, it has imaging. There's all sorts of accelerators, imaging technology that around it, so to make it, we use it for almost any kind of time. Right? And what do we have? So like surface guidance, we have cameras that actually can track the patient's surface. So we can treat like patient surface motion, we can track, and we can gate the treatment. So only deliver the treatment during like certain phases of the breathing, or we can actually use it to set up the patient. Another system we have is Calypso. The patient, basically, these are like sort of like small GPS devices, and these are surgically, sort of like with a needle through perineum. They are inserted into the prostate. Okay, these are RF transponders, and then you excite them, and then you detect the signal, and that's how you actually know anytime where the prostate is. That allows you to, if the prostate for some reason, like there's like a bladder filling or the rectum that changes, like the prostate moves and it moves out of the treatment, like your beam, then it warns you, we stop, it automatically stops the beam, and then you reposition using these transponders. So it can be used in like not only prostate, it can be used in lung, other areas.
So these transponders, then what happens to them after you use them?
Oh, they stay. I mean, there's like
They are,
right.
so it's not,
They're just not like harmful. Yeah, they
it's not
just stay there.
really tiny.
They are very small. It's like a pencil. They're like the 5 millimeter. They're like 1 millimeter by 5 millimeter, but it's very small.
I have one more question.
Yeah.
You said that depending on patient's breathing, let's say if you're looking at a tumor in the lungs.
Right.
Oh, okay, so this is all right.
So basically, like patient's breathing, then so we have imaging, so we can actually look at this patient how much is breathing, and then we design the treatment based on this breathing. We can say, okay, but what can we do? This is moving a lot or not much. If it is not moving much, we just treat it. We call motion and compensation. If it is moving a lot, we ask the patient to hold breath during the treatment. So it stays, tumor stays stationary, then we treat. So there's one option. Not everyone can do. Most of our patients are old, elderly patients. So if they cannot like hold breath for maybe 20 seconds, then we do gating. So we only treat maybe on the patient's exhale. So that that surface technology helps us to know where the breathing is. When the patient is like the exhale, we turn the beam on, and then when the patient starts the inhale, the beam is turned off. So that's like a gating.
Is the central idea that the X-rays or the electrons will kill the cancerous cells and then the body will eliminate them? Is that
So it's like going into more into like radiation biology space. Yeah, it's a double strand break. It's the your radiation will cause some device directly actually maybe like breaking it, or some secondary ways like it creates electrons. And then those like also like a break causing double strand breaks. Single strand breaks are double strand breaks usually cause the cell to die, we set up apoptosis, and that's the mechanism of, how the radiation is working. All right. And again, continue. So these LINAC, these are attached with all these imaging. The patient on the treatment table, we are not really relying on the treatment like a CT that we did a week ago. Okay, we also CT or but we're using community, we can actually get the patient 3D image on the treatment table and just shift the patient a center right in the middle of the our treatment plan. We can use the same way for the 2D and the 3D. There's here, this one, here, this is an MV image. We can this is the beam coming in down. So this can actually image the what the radiation is. We can sometimes use it for QA. So we can say, okay, what we planned is true, the output is correct. So this is the uses, and this is the right, and these are this is the source, and this is the panel, this for the KV. And exact track is the one on the bottom here, is on the floor. So during the treatment, and these are the detectors, it gives us an orthogonal view of the patient. So we use it for maybe some critical patients, like it's a spine. There's a cord. I told you that actually we actually make a plan. The cord is not harmed, and then around the area is maybe vertebrae will be radiating, right? So we have to have sub-millimeter precision, and that has to stay, and the patient should not move. So to achieve that, we continuously monitor using these kind of imaging devices, and because these kind of will be in the way, it will be pulled back, and but these are on the floor. That allows us to image continuously during the treatment.
Is the patient held by some straps or something?
Yeah, there's immobilization. I thought about actually I put some kind of setup images. There's we call for example, there's a thermoplastic mask. I'm sure I don't know if you guys saw them. Basically when you heat them, they kind of hot spot. Patient count simulation, we put them with patient head, for example, and it takes the patient's shape, and then it's still it becomes hard in a few minutes. And then we use that every day for the immobilize the patient stays the same. Same way for the body, we have for example, blue bag. So it is sort of some small beams in the bag, and then under vacuum, you can actually once you take the air out, it becomes hard. So it's soft when no vacuum. Once you vacuum it, it's hard. Or we use that to mold the patient's body, so the patient actually stays, and then that is attached to the table. So that way, as long as patient in there, it shouldn't move, but sometimes people move, okay, and then we monitor them. And then if someone is moving, then you have to account for it. You have there's all these things. Designing these, making sure everything is all of that thinking process is called commissioning. Is go through the physicist. Okay, so all of this technology, making sure it's safe and applied correctly. Technology is there. You don't know how to use it actually. So enjoy this. This is sort of like a physicist, a scientist in the department, and a consultant always. So whenever there's a problem or thing, okay, so how we can do this? Okay, it goes to the physicist. Physician always will say, okay, I have this patient, this issue, can't breathe, can't hold the breath, can't stay, it's in so much pain. A lot of half the patients we treat is palliative, not definitive. So palliative is important. Okay? So it's patients are in pain, so they want to. And when we look for it, so it's there's always this back and forth consultation with the physicians and those therapists that we make sure that everybody's safe.
I was wondering the technologists who actually performs these things,
Right.
when they train, how much fundamentals do they learn, or do they just train?
They learn quite a bit of, they don't go too deep, of course, but they learn what the relation is, how they learn basics. So sometimes the emergency treatment, they sometimes need to do, they do also their checks. Okay, in our radiation oncology, we treat patient, every plan is checked by several person. Everything is checked multiple times, okay, to make sure it's correct. Okay, it's not one person does, the second person goes, checks that work, and then my work, physicist, goes to therapist. Therapists look at the plan again, make sure prescription and the plan is agrees and the plan looks correct. They look at it from their point of view. To be able to do all of that, they need to get some understanding of what we're doing. Radiation, you need to know radiation safety, how the radiation works. Maybe they don't work they don't know too much on the details of how, you know, how, even like radiation biology works. But they know like radioactivity, like half-life, there's certain things they know how to do it and what's important. Okay, you had a question?
No, I think you already answered that. So I was only thinking like a team, how many people? You already said it's a seven.
Yes, so, yeah, the team, we have physicians, physicists, well, I guess I should say like top down, physicians, they have the patient, they consult, and then they prescribe, and then dosimetrists do the plan, physics, consulting with the physician and dosimetrists, we make sure the plan and everything is done correctly, and then therapists will do the treatments. And then like all other like front office staff, like they do like appointments. There's nurses, you know, there are some patients with anesthesia or some stuff like we have to have nurses. And there's a whole lot of stuff. We like support people. Okay, and maybe one of the most important part of the LINAC is right now that allows us to do all that like fancy treatments, dose shaping, etc. Is this multi-collimator. So this actually like very revolutionary thing. Now this MLCs, these are tungsten beams. They are about all right. So tungsten beams are like about 8 cm thick. Basically blocks the radiation and they can move. This allows us to shape the tumor. And then as there was gantry, you saw the gantry, rotates around the patient. This takes on the treatment planning software will calculate the best way to spare the normal tissue and also like irradiate tumor. Okay. That's what's and it's right in the gantry, yeah, right there.
What is it? Like these are very thin.
They are, yeah, they are very thin. So at this patient, it's about 2.5 millimeter, but it's up there, it's like maybe 2 or less than 2, maybe 1.8 millimeter. They are very thin. Okay. And there are like 120 of them. And then there are very thicknesses, like the central ones are sometimes thinner, and then like outside ones are like 5 millimeter.
So actually, I have one of these linear accelerators done, and I was surprised how loud it was, you know why? What's?
They're actually not loud, I mean, maybe there was some, like, because it's, I don't know how many tons, but it's heavy,
Yeah.
you know, the
No, I mean,
whole
like,
thing
when
is shielded, right?
I mean, when it was actually doing the reading.
It shouldn't, no, I never been in the room, that's something I always like, outside we have a noise, like, if the beam is on, it makes a noise, it's just like artificial noise, it's just like for us, you know, the
For
beam
me
is
to
on.
know that I was being
Yeah,
radiated.
but I haven't been in the room, so, but we can actually, we always have the audio visual, so we can always talk with the patients.
Yeah.
And I hear what's going on, and our machine don't make noise. If they make noise, we call service, say, hey, like, you need to oil something, you know, right? Maybe some screws are loose and maybe, yeah, so, okay. Okay, so then you know the next one is the generalized information, right? It's mainly for the primarily for the brain cranial diseases or like AVMs or trigeminal neuralgia, you know, or some other non-cancerous like things that are happening. So gamma knife is used actually for a lot of stuff. Primarily cancers, multiple metastasis. Metastasis is like one of the main uses. The patient with has lots of lesions, and this can actually treat in same day. Patient come in the morning, get imaging, plans are done, and then treated, and then they should go home, and in only one fashion. Typically, okay. It's using so this machine is the only way to turn it off is maybe putting some shielding. It has a reactive cobalt-60 in it. The LINAC is basically power off, radiation is gone. This one is always alive. Okay, so you have to put extra security in it. It's a very high activity machine. Cobalt-60 half-life is very long. It's very nice. It's like 5 years. So you have to only change the source every 5-6 years. Okay. And it's primarily for like the brain lesions and patient mobilized. That's it. And then this is how it looks like. So it has like 192, this particular model. It's about around that, 200 to 190 sources distributed around.
So this is where inside that, like, inside the machine. And the sources are, this pulled in, out, and shielded. You can turn on like certain ones. So you have basically 192 directions in the patient's, around the patient's head that you can point, that allows very conformal plans. Like this is planning. That was one of my plans at that time. I was resident that I did. So these are the things around. You turn on, off. There are different apertures that help to shape the tube, shape the those around.
How is the depth determined? How, I mean, there's a gamma ray going through.
Right. So this is the energy for scope 6 is 125. It has like 2 energies, but the average is 1.125 MeV. Okay. So this is it's a gamma ray.
Right. But can you focus at a certain depth or no? It's a little.
Well, what we do is right. I should explain it. Like, why we have like all these brushes needed, right? So we're spreading the energy throughout the surface. Otherwise, if you go one direction, you're gonna have like maybe skin burn right there. Okay, because the aeration, the X-ray works is enters and exits. There's an entrance door, exit door. It comes in 100%, exits 60%. The remaining is staying there. So the idea of all these like different directions coming in, we are trying to spread the energy, and also like all these differences helps us to shape the dose.
So when all those
intersection-
things
Yeah.
intersect is
Right.
where the tumor is, and it's high intensity only at that.
Exactly, right, exactly. So you have 100 beams. I mean, typically we don't get that many, but you have 100 beams. For each of them, you have 1% of the radiation that's targeted at the tumor. Okay, and the tumor intersection is the depth is like related. It depends on the energy. So this one is like it doesn't like work penetrates deeper, but this has like all around. So like either tumor is somewhere like closer to one side or closer to the other side. But this helps you like basically. If it's closer to one side, you go from this one. This is sort of a lower energy one, right? But the LINAC, 6 MV, maximum energy going. So there's a whole energy profile. Average energy over there is going to be like around 2. Okay, so this is 1.25. It's not too bad. So that's like the maximum dose is at 1.5 cm. But then you can treat like 10 cm easily with these. Then you have 10 MV, they're like patient large. You need a high energy. Another device is the robotic cyberknife. Okay, so this is a like robotic arm. It goes around the patient, and then like it uses the basically there's a better angle that you can go. With the LINAC, you have only one coplanar, right? The only way to do non-coplanar, you keep the couch, you like rotate the table, right? And then you can come, but then you don't have the like. Then you can collide the table, gantry can collide on the other side. So there's all these limitations, and it's like it lengthens the treatment. But with this one, the patient is on the table, and then you have the robotic arm. The disadvantage is it's only like a short length, so it's a short waveguide. Only energy we have is 6 amp. Okay. So, but for most patients with treatments, this is fine. Okay. And this is typically used for against stereotactic. It's like that's treatments that need high precision. This is also equipped with all the imaging technology and tracking the tumor. Like it has also like an exact track. It has the exact track system, and it can actually detect the patient surface guidance. So it's always sometimes we have this hypo thing that it actually tells you where the tumor is, and it's only beams on turns on when the tumor is within the field.
Since this is like more of a moving machine,
Right.
is the calibration more like rigorous?
There's a calibration, yes, right, exactly. So it's like gamma knife, the frame sign is like stationary, right? It's like people prefer it. Sometimes you don't even like you always have like safety margins around the some people when you treat like all of that shit, they sometimes people don't add margins because patient is like sort of stationary in the other things like entry is moving. It's a very good point. So this one is moving. So you have to account for it. But these are actually very nicely done with all the technology. It gives you some millimeter. So like that actually when you really the radiation, you are within 1 millimeter But if you think about it, you have like a large tumor, 1 millimeter is nothing.
Does this have potential for remote surgery?
Remote surgery?
Yeah, like someone, like a.
So all these things are happening actually remotely. No one is in the room because this is radiation. All the patients getting radiation. So if we are outside, so anything here is remote. You can stay with the patient in there. So this is basically operating. This is planned for like in a computer. You make a plan. That computer plan that you put it in, it knows where to go. So it's actually the whole operation is actually.
I know, like, so like someone in a different hospital could control it, or
It would have to be like something happens, so who's going to come in the room? You have the therapists, so doctors are not there. Therapists are treating. Therapists are, we always have camera visual, we always look at the patients on the table, they can like fall from it. It's not really, you can't really, I don't think these will ever work, but you go in and then get radiation, or something, like in a ballroom or something. These rooms are also shielded with 1 meter, 2 meter like walls because it's radiation. We are trying to protect. We're using concrete most of the time. Concrete is cheap. And then we just need like 2 meters. It's like 1 meter, 2 meter of it. These probably less, but the Linux usually only you have to shield the primary wall, and this one that is moving in different directions. We have to consider all of that, so that makes it too.
So I really like these, but in the interest of time, I really want to learn about career.
Oh, yeah,
opportunities.
what are we doing?
Students to learn about career.
Right, okay. I mean. Okay. Oh, okay. All right, I'll skip these. Okay, so these are some of the most devices. Now, thank you for the time. So these are all different devices, and the medical physics is a career. Okay. These are I kind of mentioned like what we do in the clinic. These are the medical physics responsibilities. Physicists. These are all the things we do. And okay, when you become a medical physicist, there are you have options in like you can clinical careers, you can work in hospitals, cancer centers, you can be a solo physicist, or you can work with multiple physicists. Okay, and you need to have either a master's degree or PhD degree. Okay, academic careers, usually like university hospitals, you have more responsibilities like the research and the teaching, and it will require a PhD degree. Oftentimes these are not tenure track because still like they are funded by the hospital income from the treatments. Tenure track positions in the medical physics is rare. It exists, but it's not very common because that person is basically dedicating 100% research, bringing money, etc. And oftentimes people are not tenure track. And there's also industry careers. All of these like manufacturers, like hire physicists to improve their system, build things, salespersons, there's all these options that physics is a career option. So how to become medical physicists? There's a certification body, we come into radiology. Okay. For the radiology certifies these subspecialties. Okay. The therapeutic physics, diagnostic with the American Board of Medical Physics, does the health physics and MRI physics. Okay. So we need to get certification to be able to practice physics, medical physics, in most states, in most scenarios. All right. How do you get the certification? All right. So now you need to take 3 exams. Part 1 exam, part 2 exam, part 3 exam. Part 3 exam is the oral exam. Right? To be able to take part 1 exam, you need to be enrolled or graduated from a CAMPEP accredited graduate. It can be a master's, PhD, or a certificate program, or a residency program. One of these 4, you see the term CAMPEP. CAMPEP is that you can take part 1. Okay. Part 1 allows you to take part 2. Okay. The whole goal is you take part 2. But part 2 is you need to actually be graduating from a residency program. Again, CAMPEP. So to be able to be certified, you need residency training. Now, that's the only option, almost only option. Okay. And the residency program, finish it and you take part 3, pass, that's an oral exam, pass it and you're board certified. Okay. Campus residency, but how can you go into a campus residency program? Okay, now that's the part that interests most of you. All right. You need, we are looking for a strong foundation based in physics. So what is the definition of like from the campus and strong foundation? A higher level, at least 3 courses. Okay, like 300, 400 level. You need modern physics, modern physics, those 3 you did. You're a biology major, but you did take those 3. You have a basic minor in, for us, you have a minor in physics. Several people that know medical physics coming from biomedical engineering, okay? And then they finish it, they didn't take these, they go ahead and take these 3 courses, and then they sort of like have a medical requirement. That's the requirement. It has to be upper level. You can't say, okay, I did like 111, 105, just that. Basic Newton mechanics, and then that's okay, that's not enough. Okay. We need like more understanding. When we talk about radioactivity, we need to be able to talk the same language. Okay? So, and also, the dynamics of all operation on the fundamentals of the wave-guided to that number. All of that, so you have to understand. And then once you have that, at least, then that's you do a campus accredited MS or PhD graduate program. Okay, so you have a undergrad degree, physics or like the requirements, and then you complete one of these 2 master's program or PhD program in medical physics. If you have a PhD program, PhD from the field like I did for physics or PhD, so you could do a certificate program 1 year. You take all the courses, about 6 of them, or you take 6 courses from a accredited institution. That's also satisfied. Then you can apply for residency programs and you can be accepted.
If the student's interested in pursuing this route, is there some resource they should know about to find a list of compact accredited?
Yeah, there are. Go to Campact, search it, and then you are in the Campact website, and there's all the list of the programs that are Campact accredited. All masters, PhD, and also, So, masters allows you to go into the residency program, and actually, it's a short path. PhD takes 6 years, 10 years, depends. So, you finish your PhD, and then you get it. So, but if your goal is not to be an academic and you just want to be a clinical medical physicist, somewhere practicing this, it's a very short path. Finish undergrad, masters, 24 years old, you can do for residency, 26, you're board certified, right? I got board certification at 35. So there are differences, right? But then you're like more academic role, you have to think of what are the options. You can always come back. Just like if you did something out, you should try and visit. These are the options. This is how you can do it.
So a lot of med programs for physicians, it costs a lot of money. So for these programs, are they usually funded by the hospitals? Is it like when
it's
you
not
get
funded
into
by
it?
the exactly. So that's why it's right. So our residency programs are not funded by Medicare. It's funded by the hospital fund usually. So, but it's not gonna cost anything to the residents. We pay residents or residents salary. So that's it's enough to survive. So yeah, there's DMP programs. They combine sort of a doctorate residency. There's that program too. I haven't mentioned here, but that DMP, you're doing a residency program, sort of guaranteed when you apply for it, sort of like a master's or PhD program. It's not a PhD. They call DMP, but for those programs that you pay, okay. And that there are not many of those. There's other options, dosimetric, like we sort of like work hand in hand. They do treatment plans, mostly work with physicists and physicians. They contours, normal structures. The contour works takes a lot, and then physicians are busy, so they help them. Okay? And they do the treatment plan, treatment documentation. They have billing. So they don't really have to be in the clinic now as often. So, I guess it's easier to become a dosimetrist as rigorous education requirement. You just need to. I will explain that if you have to. less sort of responsibilities, better working hours. We for the QAs has to be, we have to stay after hours, right? Patients are treated during the day. Any QA has to be done after patients are go home after 5 p.m. Just to stay till maybe 8 p.m. Okay? So there's like that option, that things going on as well. And some they can actually work maybe from home. So right now our docents are working from home. Physicists, we still have to be on site. Right, it's like something at the machine, they call us, we have to be available for the senators. If they're available over the phone, computer, Zoom, Teams, that's fine. But of course, like that, so.
All right, so when you say less pay, what's the typical pay for a dosimetrist?
I think like maybe 25% they're getting less paid right now, like compared to physicists, maybe they're getting 150.
150.
Right, yeah. Right.
That's like a starting salary.
Yeah, something around now, it's like they're like high demand. Yeah.
That's a very good point. When you say less pay, it's like.
And the person, so it depends on the locality, so it's like, if you are somewhere, maybe like in a different area, you pay maybe slightly less, like using condition level, so it's just like, there is APM salary survey, it's available, search APM salary survey, it tells you how many years of experience, where, which state you are in, it tells you what the physicists are making. Okay? APM professional salary survey. APM is our like sort of professional society. They do this survey, and then that can give you an idea of what the things are. Medical dosimetry certification, there's a CMP exam, so they require a minimum bachelor's degree and a graduate of a JRCRT accredited medical dosimetry program, at least 12 months long. Okay, there are certificate programs, there are master's programs, there are bachelor of science programs. So basically, with finishing your bachelor of science, you can do. I mean, most of these programs looking for therapy certification. So if you don't do that, maybe you need to do 2 years. Okay, there are programs that you combine that. So you need to learn minimum level, the radiation didactic information they teach you. But it can be as like short as like 4 years training after high school, and then you become dosimetrist. All right, and then you have medical physics assistant. So it's like you're looking for a job. You want like it's medical physics. You are looking for like let me explore a little bit. Just like you want to really see the environment. This is something for me. There are jobs like all medical assistants. They help us do the QA, like after hours when people don't want to stay. And then there's always patient QA and things like that. And then medical assistants do those kind of jobs, and it's papers. And then that gives you an insight of the field, and actually that gives you experience as well. And maybe you can be a preferred candidate or at least because you already know like all some of the stuff. So that can be a dependent thing. I think it's my last slide. Thank you for listening, but I'll take some questions.
Do you need a lot of certifications to get to like the step of like medical physics assistant?
No, this doesn't require anything. So we are looking for someone.
A physics major
Yeah,
can
a
apply.
physics major can apply. Even like a chemist major can apply.
Or like recommended coursework, maybe?
No, nothing. Of course, we are looking for someone who can understand this. You're going to be dealing with software, just like technically chemical. So, how to. You're going to have to write reports. You're going to be writing the reports, showing me the work you did, explain the work you did, and then you convince me that actually like the work is correct. So now I'm like I as a physicist signing off your work. So I need someone that I can trust. Like follow the directions and do the work. We will do the training each year. But you should be able to do those tasks. Follow if you want. Once you train, you just follow these things and communicate. Yeah. Thank you. All right, I couldn't go through all, but just maybe another time. Yeah.
By the way, for the students, we have our former students who went into medical physics careers, and then also dosimetrist careers. One in Loma Linda, we have a medical dosimetrist. She's a former student of ours. So it is really, it became careers for some of our former students.
I have a brother who went through radiation therapy recently, and he said he could see shrink off radiation in his eyeballs during the treatment. So I'm wondering how, it was showing me some literature that actually really other people.
Yeah,
can also.
I showed surface guided, so that laser can actually have cameras that actually detect the shape of radiation.
Yeah.
So it can be used curing and things like that, yeah.
But his eyeballs were acting as shrink off detectors.
I don't know how, yeah, I don't
So
know
like
how that
your
would be.
eyeball.
Yeah, maybe it is possible, I don't know much about, yeah, I don't know how that's gonna be, so where was he getting the treatment then?
I think the city of Colquitt was.
No, like the area.
No, as I said, we had a
Oh, yeah,
razor with
maybe.
tumor lasers,
Yeah,
yeah,
I
so I
don't
think.
know.
Sure, he was really seeing it or.
I mean,
No, apparently I was, we looked up some
Right.
papers, that's,
Yeah.
people have done some research on that, because there's water in your
There is
eyeballs. You
sharing
have,
radiation, I don't know if you can see with eye, I don't know.
creates visible
So
radiation.
we have special cameras that can see it.
The blue glow in swimming pools you see around reactors, right?
Yeah.
Shrink off radiation.
Okay.
Just to be clear, students, none of this is gonna give you superpowers. A lot of it sounded like comic book movie adjacent, it's not.
So, well, if there is no more questions, then thank, how you want to make, so thank you.